Yeah, thanks for having me. Phil's right. I am passionate about family history, but it dawned on me that actually we need to talk more on family history here. I can't get every category of people, but how many GPs here, including academics? Okay, that's fine. Okay, how many people from CRNs? Secondary care? I'm sorry about the others. I can't give all the categories, but I'll stop there. Okay, so what it was is, what I wanted to discuss really was about the practicalities of doing genetics and genomics research in primary care. The something old is where Phil and I come from, is the family history. The something new is trying to get genomics testing and genomics into primary care. So I'm trying to jump between the two of them. I don't know if it'll work, but tell me afterwards. Okay, so the academics here will appreciate you can't go straight to an intervention. There's several steps on the way. And so it's similar to the complex intervention framework. So someone brought up the issue about compliance. If you're going to an intervention not having appreciated the process before that, you might have lack of compliance with the intervention simply because you haven't designed it properly. So what I want to do is just go through this process with you. The other aspect is, the experience from Nottingham is, we engage GPs better if we can anchor it to things they know about. So I could talk for a whole hour about this slide, but taking into account the screening they do, taking into account which guidelines they're actually involved in, taking into account healthcare policy that brings genetics and genomics in. So this is often our anchor when we get into practices. So just running through the approaches. So for over 15 years, we've been doing qualitative work with GPs to see what they're engaged in, what triggers them to be inspired about genetics. And one thing that came out of a Wonka, and the GPs will know what Wonka is, no one else, I can't remember what it stands for, a Wonka conference, we actually asked GPs about what would get you into genetics. And they said it's the family history. The GPs in the audience will know about this Stott and Davis model of how you think of the consultation. But also they thought the consultation has the opportunity to consider the family history. And there's a nice quote from a prevention physician in the US who said, family history effectively bridges clinical medicine with public health by focusing risk assessment at a level between the extremes of one at a time and one size fits all. And that sounds very similar to stratified medicine, doesn't it? So, and the other thing, so we've actually done work with GPs, and a recent project we've just completed is asking GPs how they feel about genetic testing for FH in general practice before we actually went out and did genetic testing in general practice. And this is a quote from a GP. I know the initial cost of each test may be expensive, but it involves early identification of disease versus long-term cardiac care. Then it is cost effective. However, and this is the important thing, we need to ensure GPs were familiar with the implementation criteria. So as well as that, right from the beginning, we've been doing plenty of surveys with GPs. And this is one of our early surveys, which asked GPs, if you were to offer assessment of familial breast cancer and colorectal cancer, what sort of service would you want? They weren't mutually exclusive categories. But generally, GPs were reluctant at that stage to be more involved in the process. And the next slide is very blurred, but it's just more of a plug than a slide. We're at the moment with Imran and Judith, who I think are in the audience down the back somewhere. We're doing a survey of GPs to see what are their educational needs to take on genomic medicine. And we'll be handing out, actually, I'll hand it out at the end. If the GPs will take one of these leaflets, there's a QR code on it. So if you feel inclined, please fill in the survey. That's my plug done. The other aspect, before we even get to intervention, is doing qualitative work with patients. And again, using family history and genomics. When we ask patients about the role of family history, some were more in control and thought they could do something with it and say, my family were overweight, I really want to stop the disease progressing. Whilst others were fatalistic and said, it's running in my family, if your numbers come up, you can't do nothing. So that was in the past, something old. But we've also done research with patients who've had genetic testing for cardiovascular genotyping. And again, we get these two camps. We get patients who are positive and say, I think the two together, that means both standard cardiovascular risk assessment and genetic testing, the two bits of information may just help create a greater incentive for me to change things. And then the negative side, well, it scares me, genetic testing. It's obviously I want to do everything I possibly can to avoid them, but to avoid getting any heart disease. So that was the negative aspect. So what other things? Again, before we've gone to interventions, as the other academics here will appreciate, we've done a series of systematic reviews. Each area we've looked at, we've done a systematic review. And this is one that we were commissioned to do for the NIH in the States. It was a consensus statement about the benefits of harm of collecting genetic family histories. And it's no feat, so you need a very diligent junior to do this. So we had about 32,000 titles and abstracts, and which reduced down to 34 publications that were looking at the benefits and 38 looking at the harms, and at the end it was only 2 or 3. Painful work, but it has to be done. And I won't go through the details. The slides have the references on them. But at the end of it, when we presented this information to the consensus panel, the view was things aren't clear in primary care. It's much clearer in the clinical genetics setting. The issue is we in primary care deal with common diseases rather than genetic syndromes. And the other thing, direct evidence is really difficult to come by because there's no studies looking at the morbidity or mortality benefits of this. And the other aspect that came out, the psychological harmful thing, is there's a U-shape of anxiety. That if you have some anxiety, you will have screening or surveillance. If you have too much, you won't. And you have too little, you won't. So anxiety, in other words, isn't a bad thing. It's how it actually applies to the situation. And there was plenty of research recommendations about outcome-based research that needs to be done, but also looking at psychological research into what motivates health behavior change. And also, is there any harm of misinterpretation? So that doesn't just apply to family history research. That applies to genomics research as well. So the other piece of the puzzle is we've recognized through various studies that family history is poorly recorded in general practice. This is just bringing up part of my MD. I've got some more interesting stuff, but I want to remind myself I did an MD. So this just shows that actually it's poorly recorded, and more important is that what you really need to take an accurate family history is know the age of onset. And that's really still quite poorly recorded for lots of conditions. So what we did was develop a family history questionnaire, which compared the collection of information from a family history questionnaire to the same collection using standard pedigrees with clinical geneticists. And we were looking for 3 areas: single gene disorders, coronary heart disease, and familial cancer. And we got around a 77% agreement between the two, between our approach and the gold standard. So that was an example of one page of the questionnaire. But collecting family history on its own is no use unless you can do something with it. And so following on from that, we actually, this is going back 15 years, developed a simple traffic light system for, this is preceding NICE, for actually identifying patients who are at high, moderate, or low risk of familial breast and colorectal cancer. But things have moved on since then, and decision support has got better. So our study that we just completed last year was looking at using an online decision support tool to do this. And there's various aspects of this that are relevant. I'll come back to this. Is we needed a way to search the records. We also wanted to look at the impact of 2 modalities of identifying patients, whether you identified everyone using a survey or you invited people opportunistically. And we want to compare to control for usual arm. And then the questionnaire was entered online. And this is exactly the same as that paper questionnaire we used 15 years ago, but it's now online. And from that, we develop a decision support related to NICE guidelines. Either people are average risk or cared for in primary care, or moderate high risk who are actually referred to the specialist service. And this is automating decision support into primary care. But what's interesting is going into the genomics era, based simply on the family history, or if you use something more elaborate like the tools that Gareth Evans is producing in Manchester. I don't know if he was on TV yesterday about his tool. I don't know if anyone saw it? Yeah. So it's actually either using that approach or this. You can predict the probability of getting a mutation. And one thing I want to postulate, and I don't know how Julian feels about this, if you know someone's high probability in primary care, could the genomic test be done in primary care? So that's something we could consider. The other aspect is there's no point doing an intervention in primary care unless you can assess the outcomes properly and identify the cases and controls. So following on, as I mentioned from the study on familial breast cancer, we developed a tool to identify baseline and follow-up, what is in the change in the recording of information using automated electronic health records. So we looked at family history recording at baseline. Also, we looked at outcomes of interest in terms of compliance with NICE guidelines. So we collected this data at baseline and at follow-up. And so the difficulty you often have in general practice is actually how to collate the data. What we've had to do in, as well as automated collection is manual searching. And this is because the coding's not correct yet. So we have to still do the manual searching. And I think the next slide's about, so, yeah. I think what's quite important is that actually, if we are going to identify cases for genomic research, we do need to have a clear idea of the phenotype. And so a lot of this work's being done in the States, is identify possible codes from the condition, the medication, administrative codes, consider dilemmas of where conditions overlap, exclude risk factors. So an American study looking at phenotyping for asthma, they've excluded people if they've got a 10-year history of smoking in the asthma, so they won't take them. And I think, Bruce, you've done work like this before, haven't you? So it's important in terms of identifying cases, you get this right. And so some areas where it works out really well is if you've got few computer codes. So we've been quite lucky with our familial hypercholesterolemia work that it's relatively rarely coded. We have problems that sometimes people code as pure hypercholesterolemia, but we get around that by looking at other codes for cholesterol and that. If there's specific treatments, then that helps in phenotyping. A longer duration of data entry. And as we had in this country, is some incentivization for accurate diagnosis. So really, we can't do the research unless we get the coding right. And the big problem we have, the burden we have when we do research is we're still having to go back to the manual record to find information. So as an example, this is from the States, is by using specific coding, history codes, symptom codes, medication codes, and billing codes, they've got to 95% positive predictive value, 96% negative predictive value. But to achieve that, they've lost 24% of cases. And another practical issue from our research is when we started doing our familial hypercholesterolemia research, we had a dilemma because we were trying to identify people who had FH in the notes. But what the problem we had is we didn't have a code for xanthoma. There was no read code. So that caused problems, so we had to go back to the manual records. So having done all that mixed methods research, hopefully we've optimized our interventions, our outcomes. We're relatively confident we're running things so we'll get optimum recruitment and adherence. And then we can go to developing interventions in primary care. And Phil and I were involved in a study where we did a very simple study, but it was a very complicated study. So it was looking at if you incorporate family history recording into cardiovascular assessment, how will it change the number of patients that are actually identified at high risk? And the simple thing was that statement. The hard thing is we decided to do a matched pair cluster randomized controlled trial, which made life really difficult. But at the end of the day, we found there was a 5% increase in the number of patients that were identified at high risk if you properly recorded the family history. At the moment, we're doing a study looking at if you actually identify patients at high risk of familial hypercholesterolemia and offer them genetic testing in primary care, if you can identify a higher proportion of patients compared to standard approaches. So the first phase there is actually, like with the familial breast cancer, is to develop a data searching system through MyQuest in this case. And then the other aspect we've brought in is that we're going to offer in primary care genetic testing not only for the standard mutations, which are for monogenic FH, but we're also going to look for polygenic disease. And it's all up in the air at the moment, but it looks like the polygenic disease will have to be managed in primary care. So I'm not going to go talk about the current, because I've got Stephen Weng, who's my research fellow, is going to present that study in the slots in the afternoon. But one thing I want to remind people is that actually, whenever we introduce a new service or opportunity, it can increase health inequalities by skewing up services away from those that most need it. So not only in service provision, but in research, we need to be conscious of that. So we deliberately in our research try to recruit practices from underserved areas. We get lower recruitment, but we think it is important that you do recruit across the spectrum. So I'm going to leave on that point. Thanks a lot.